Bienvenue and welcome. My name is James Cross, and I'm honored to serve as the President-elect of the Canadian Academy of Health Sciences. Thank you all for joining us for our first dialogue of this year, our sixth episode in this series. These informal Academy-led conversations are on a wide range of topics, from new frontiers in science to current issues surrounding our healthcare system. And they are open to both our fellows of the Academy as well as non-fellows, with the goal of increasing our collective understanding of health sciences, and through this to increase the trust in science in our society. Personally, I believe that the diversity of knowledge and perspectives makes us a stronger academy, and indeed a stronger country, as long as we dare to embrace it and nourish it. Let me repeat that. Personnellement, je crois que la diversité des connaissances.
Personally, I believe that diversity in our knowledge and perspectives makes us a stronger academy and a stronger country if we dare to embrace and to nourish it.
In that spirit, it is important to recognize that the offices of the Canadian Academy of Health Sciences are in Ottawa, which is located within the unceded and unsurrendered Algonquin Anishinaabe territory, whose presence there reaches back time immemorial. We recognize the role of the Anishinaabe Algonquin Nation as the customary keepers and defenders of the Ottawa River watershed and its tributaries. I work and live in the Treaty 7 region in southern Alberta, which is the traditional territory of the people of the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda people, which includes the Chiniki, Bearspaw, and Wesley First Nations. This is also the traditional home to Métis Nation of Alberta, Region 3. I pay my respects on our behalf to the traditional elders of these lands, past, present, and future, and extend that respect to all First Nation, Inuit, and Métis peoples across what we now call Canada. This dialogue series is an initiative designed to showcase the wealth and range of knowledge and perspectives, and therefore the reach of our Academy. I invite you to be a regular part of these events. Please note that the views expressed at these dialogues and other Academy events are those of the participants and not the Academy. La diversité compte. Diversity matters, especially with what's going on in the world today. Let's embrace the diversity that we have. It's our strength. We are extremely pleased to be doing these events in partnership with Desjardins. Desjardins is the Academy's bank, and they've graciously provided financial contribution, which enables us to keep this series free of charge. But before we begin, I have a few housekeeping notes to share. Today's discussion will be held in French. I'm very pleased about that, but we are happy to provide English simultaneous interpretation today. You may choose the English language option at the bottom of your Zoom window. The chat bar will not be active for those of you in the audience, and that said, you're welcome to ask questions or add comments in either French or English using the Q&A button located at the bottom of the Zoom window. And so get that set up if you want the translation now. And now for the show. Pour le dialogue aujourd'hui, j'ai le grand plaisir de
For
vous
today's dialogue, I have a great pleasure of introducing Dr. Marie-France Leno from the University of Montreal and member of the Canadian Health Science Academy Board. Marie-France, over to you.
Thank you very much. Bonjour à tous.
Hello, everyone. Thank you very much for taking part in today's discussion with the Academy this afternoon. I'd like to spare a thought now for Ukrainian people living in Eastern Europe as well today. We're all very concerned about what's happening. At least we can show them that our thoughts are with them. It's a great pleasure to introduce our guest today, Dr. Charles Massé. I have to tell you that I met Dr. Massé when I was a student at McGill University a few years ago now. So long ago now, in fact, that I started by being very, very informal with him, and I'll continue with that today. Rather than introducing Dr. Massé myself, I'd like him to explain his career to us, starting when he left the university. Dr. Massé, over to you. Hello, thank you very much, Marie-France. When I started my studies in medicine, I had the goal of going to work in the developing world, and that's what I did when I finished my medical studies. I went to work in Africa for many years, and then I started to work in a local community healthcare center. And when I was in my residency, I went to work in that at that time. It was important because that clinical experience was very, very important for me, and it had a great influence on my knowledge and my view of things. I continued my training in public health, that was my specialty, in fact. Then I worked in community health centers across the island of Montreal. Later, I became director of public health for the Montreal area. And later, a few years later, I became national director of public health. You call it chief medical officer in English. So I was the equivalent of Dr. Arruda or Dr. Bonnie Henry in BC, or my colleagues in the other provinces. I was there for 5 years, and that's when we passed to the Public Health Act, and that was very, very useful for the pandemic period. I was CEO of the National Institute of Public Health, and then I worked at the public health department of the University of Montreal. I was the first director of that school when it was created. So that allowed me to represent Canada at the WHO, and also as a Canadian representative of the Pan American Health Organization. I was Canada's representative for about 10 years. I worked with Canadian colleagues from across the country. It was a great privilege to see what was going on across the country and across the world in terms of public health. And I was able to actually see firsthand the difficult decisions that were required. Thank you very much. Throughout your career, what we're really interested in today is the last part of your career. You were the strategic medical advisor to the health ministry starting in March 2020 until August 2021, at the start of the pandemic, therefore in Quebec. So you had a ringside seat. Could you explain the work that you had to do in that position? Well, Dr. Arruda, who was the chief medical officer of Quebec, he asked me to help him because it was important to respond to requests and questions. He really required someone to help him, to really establish a link between the health ministry and his organization. So I was there to coordinate the team and also to participate in the board, and also to participate in liaison or links with other departments or ministries. So there was a lot of interface, a lot of interaction with the other government ministries. I was also there to actually coordinate public health activities. So that's what basically I did. So the whole internal functioning of the network, well, I was responsible for that. We worked as a team. Then the team was expanded at one point, but I have to tell you that during that period, I had a very, very strong tie with the executive team. I'd like to interrupt you because for our colleagues in other provinces, I didn't understand what the Executive Council was. Could you explain what it is exactly? Well, the Executive Council is the Premier's office. It's basically the organization that coordinates all ministries across Quebec. The personal the person who's responsible for that is basically the Premier. So during the day, I worked in the health ministry, and then I would take part in evening meetings in the Executive Council, and we talked about decisions that were required to be made. We were constantly adjusting. I'd just like to add that during that period, I had contact with all ministries and organizations, but I spent 10 years within government as a deputy minister and as CEO of the Public Health Institute. And over 18 months, I think I had 10 times more interaction with government organizations. It really shows you the level of cooperation, the sharing of scientific information, the coordination of decisions. Because as you know, most of the decisions that were made were ultimately political decisions. These were the decisions made by the government during the pandemic period. Could you explain in detail, because today's topic is the link between science and politicians. What was your specific contact with politicians, with decision makers? Can you tell us about that? Well, first of all, I had contact on a daily basis with the Minister of Health or Ministers of Health. There are two deputy ministers and a minister, so I was in contact with them on a daily basis, and that was through the Executive Council. There were ministers that were invited to participate in the council meetings, depending on what we were talking about. So I also had frequent discussions with other ministers. If there were presentations we were to make together, or discussions about decisions pertaining to the lockdown or lifting the lockdown, how we protect students, how we protected workers, how we protected childcare centers, etc. So my contact was very, very frequent and at various levels. Generally, it was very respectful and very effective, in fact. Let's get to the topic which we're really interested in at the Academy. What was your role in bringing information to politicians, scientific information? Well, that was my main role, because we weren't responsible for the political decisions. So we make recommendations, we advise based on data and the knowledge and of the effectiveness of interventions, and about technology, therapies, diagnostic technology, all that. We were well aware, however, that the ultimate decision was a political one. So we were really the interface, if you like, at the interface of the decision-making process. We were also aware that science was essential. It was a requirement, but it wasn't the only input, if you like, in the decisions. There was social license, for example, that was important. We'll talk about that later. There was ethics, feasibility within the healthcare network. These were all factors that were taken into account. They're just as important as science. Now you have to accept that there's a part based on science, but there are also other issues that are taken into account, and it's that interface between science, data, and the decisions that the government makes. That's where I was. We would have a dialogue. It was an ongoing dialogue between both sides. It wasn't only ongoing within the public health network, but also within the healthcare network itself, and also within the academic network, because for some issues we need to bring in experts, experts from various institutions, experts on public policy, for example, experts in research. We needed them. We also needed to talk to scientists across the country and across the world, in fact. It was the biggest plagiarism exercise that I've ever been involved in. We were able to learn from each other. We were able to learn from what other people were doing, from their data, from their experience as well. Because there were many things that weren't necessarily published or fully published, or were very different from the processes that we're used to. So we had to look at all that information, and some information was published, some information was not, and we had to really delve into all that. So it was important to have this national and international network that we could learn from and that we could also provide information to. With hindsight, you've been away from the actual battlefield for 6 months now. What would you say the role of science was during the first few months of the pandemic? Answer, well, science was literally fundamental because we need to know what we were dealing with. It was very different from what we had experienced in the past. We had to understand what the incubation period was, what the potential transmission period was, what was the virulency of the virus, or viruses plural, because there were several. And then, what should be the response? What should be the measures taken to protect people? PPE, for example, and preventative measures to prevent infection or to prevent transmission between people. What needed to be done? So we needed scientific data so that we could decide what to do. So epidemiological data to the identification of vulnerable groups, taking precautionary measures to protect those people, monitoring hospitals, clinical services, what was happening there, and also what was happening with workers, healthcare workers. Clinical science, well, apart from that, there was social science. That was very important as well. There were a lot of perception issues about the measures that were taken. This is still the case today. It was important to understand those perceptions and to listen to people so that we could inform people and to adjust really to what people's needs were. So science was at the heart of our decision-making process. It was also important for ethics as well. We'll talk about that later. But science was really at the heart of all the decisions that we were required to make. There have been technological developments over the past 2 years, which have been major, significant. The monitoring system, for example, providing information on the disease, on the virus, or on a person's vaccination status. These are tools that have been developed, which will have an impact on the future, I think, even if they were not always developed enough or as at the level they were supposed to be. So we've been able, this is a process, I think, that will pay off for other viruses, for other diseases. I think everything we've done, all the developments will help us to actually fight other viruses, including HIV. I could continue, I could say more, but I think scientific development was major, significant. It's very important. We know that we don't have the knowledge we need to deal with the virus. We know a lot more about it, but there are still things we don't know about. A provocative question now. Are there things that researchers did that irritated you? or the way the data was presented? What things irritated you or annoyed you? Well, there was a lot of lobbying from people developing various products. And sometimes these initiatives were major, significant, useful. Other times, people were very focused on their products, the products they were developing, and they didn't think about any other considerations. I'll give you an example. I mentioned this earlier. If you look at the monitoring systems, individual electronic monitoring systems, bracelets, or devices in our smartphones, and some of them were designed actually to allow people to know if they've been in contact with people who were infected. Now, there was a lot of pressure brought to bear on us, but these tools are not yet acceptable, and they don't yet work very well, rather. So a lot of effort, a lot of focus was put into these tools without us really understanding how they work, how they could work, or whether they worked. I understand the limitations of tools. Like elsewhere in science, there are various schools of thought, various opinions. In public health, there have always been people who have taken a risk management approach. They accept that risk is inevitable and has to be managed. Others prefer to reduce risks to zero. And if you are part of that school of thought, that leads you to extreme decisions. And it means really that there was a lot of tension, and it's not necessarily useful in a pandemic situation. We have to listen to people's points of view. Now, just because you're a scientist, that doesn't mean that you have a monopoly on the truth. There are other considerations you have to take into account. But there were people who were focused on one issue, one single issue. That's not new, but this was a phenomenon that was exacerbated during the pandemic. It's good to have diverging opinions because it allows you to think and look at other possibilities, other opportunities. I'm not saying it's not a good thing, but I think, however, that you have to be careful. You have to be careful not to really be blinkered in your thinking. Now, you said that your role basically was to translate scientific data for decision makers, for ministers, and for the premier in your daily interaction with them. Science, how was it received by them? You would imagine that elected officials during that period had a lot of responsibility on their shoulders. You were asking them to make decisions that none of them had been called upon to make it in the past. So when you presented scientific data to them, how was it received? Were they open to incorporating it, to doing what you suggested? Was it welcome advice? How did they react? Answer, well, they were very, very receptive to scientific information and data. There was a great appetite, a thirst for information to allow them to make their decisions. As soon as scientific data had an impact on decision making, they were very interested. Even things that were quite complex at first blush, epidemiological data, for example, modeling data, and we've seen that throughout the pandemic. It can be quite complex sometimes, but you do have to find a way of presenting that information without it being overly complex, but to make it useful so that people can see how useful it is for the decisions they have to make. And when you're able to do that, you'll see that politicians are very interested, very receptive. Having said that, however, politicians see things in black and white. That's very often the case. And that means they want to move forward quickly. Why don't you do this now? That's what they would say to us time and time again. And why don't you just do this right now? As you said, you should. Let's look at vaccine passports, for example. There was differing opinions on vaccine passports, but we saw that there was a positive side to vaccine passports, and then there was ethically dubious aspects to the passports. And they would say to us, why don't you just apply passports across the board? But there are circumstances that are not conducive to vaccine passports. You have to avoid adverse effects that outweigh the potential benefits. And that was difficult to explain because politicians will say, well, we do it now, let's apply it, implement it right away. They're very gung-ho. But our role really was to explain the limits to what could be done. We talked to them about ethical considerations, for example. They were important, and also the impact on other sides of life, not just health. Politicians understand that, but you have to take the time to explain clearly to them. And they put forward considerations pertaining to feasibility and intersectoral impact. At the Executive Council, for example, they were well aware of those considerations, and they would ask us all sorts of questions about work, about unions, about education, about childcare centres, and these questions are often very, very specific, and sometimes the questions were so pointed that it was difficult to give an answer. But it's important that they ask those questions so that we can make the right decisions. It was an ongoing effort, really. Very often, people think that it's public health that decided what should be done. Well, we did make recommendations, but politicians made the ultimate decision. But there were so many conversations on a daily basis that there was a very, very close interface between us, between politicians and public health. We couldn't do things in a different way. You could say, well, we'll make recommendations to politicians and they'll decide, but that doesn't work either. My experience really is that we were closely linked. We worked very, very well together, in fact. So you've talked about science, you talked about researchers and people that you actually had input, that you brought in to actually talk to politicians. What about clinicians? Did they have a role to play? Well, clinicians, they were able to provide great knowledge. There are many clinicians who do research. They know their clientele very well, and they're able to actually fill in the gaps. So they're able to tell us what's going on the ground, how the virus is changing, its impact on people, on the way people are experiencing the measures, the way their patients experience these measures, be they elderly or young. And then there's the whole infection prevention process in the healthcare system. And we saw that in care homes. It was a very, very painful experience for people in that network. So clinicians had a basic role to play in the process. Several clinicians were a go-between between academia and public health. So if we needed data, we need to generate data, we could do that. We could say, well, we need this type of information, and clinicians were able to give us that information. Clinicians working with the immunocompromised, for example, they were able to talk about the experience of those people and give us data. So that was a very, very important role, and that allowed us to make better decisions about doses, for example, vaccine doses. how much should the space be between dose 1 and dose 2, for example. We also worked with groups and associations. The Association of Pediatricians, for example, at the Quebec level, at the cross-country level, those people played an important role because they provided knowledge and data to us, but we were able to ask them to transmit information to their patients, to parents, and that was very, very important as well. It wasn't an easy role, but because it can't only be public health that provides information, it also has to come from clinicians. They can also have an influence on policy. They can actually share their view. There's a lot of information being bandied about. There's also a lot of misinformation as well. And there, clinicians and clinician associations were able to play a very, very important role in informing the public. They played a fundamental role, in fact.
Évoqué tantôt, mais tu n'en as pas parlé beaucoup, du rôle des sciences humaines et sociales, au-delà de la science de la transmission du virus, puis de ses caractéristiques, puis des moyens de se protéger. Tu as évoqué d'autres enjeux qui pourraient être couverts, puis à l'Académie, on a aussi
And at the Academy, and we've had and different participants and researchers in social sciences. Yes, in fact, it's very important because we need to set up population measures to understand the ins and outs of everything, to see how people perceive the situation, what risk do they perceive, and what kind of solutions would be acceptable, and why are those solutions acceptable or not. And we have to understand this properly. So when we attempt these measures, we have to expect reactions. We had the opportunity to have carry out almost daily questionnaires to find out, or surveys to find out how things were evolving, which helped to take decisions. And also, we learned during these last 2 years that there could be paradoxical effects happening to the measures undertaken. We know that for instance, when you're fighting substance abuse, there can be a paradoxical reaction to information and measures that can be taken. And we've seen this with vaccination. We've seen there are many people who hesitate to take it, and it has grown. And why? Because people understand the disease better and have felt pushed, and it has polarized the population. That doesn't mean that it's going to last eternally, but it could have an effect on vaccination in general. And we're going to have to look at those basics before getting back to them. So that is also, it's important to understand that. And in surveys in the media, it's important to understand this, and also in the government apparatus. So we were confronted with this very, very quickly and very directly, because when we were proposing measures, we had to look at all of it. We'd have to say, well, yes, this or no, that, or this is unacceptable because of this or that. So we'd look at these surveys on attitudes and knowledge. And this is done by all governments. So that's an important aspect. And this basis of knowledge needs to be perfected for to be used. Now, at the Academy, we also have people who are specialists in ethics. You have talked about ethics. Could you talk about some of the ethics issues that have come up. I talked a little while ago about the different kinds of technologies that exist in order to be able to monitor vaccine status to find out whether you're at risk or not. But there's a lot of issues around that. Can people who are perhaps not so honest be able to withdraw and use that information for bad purposes? Some measures were taken to stop transmission in the community, but the transmission that those measures were for protecting people who were vulnerable or chronic condition or older people with severe problems. We wanted to protect people in the population who were particularly vulnerable, but the measures that we were taking had some severe effects on mental health, substance abuse, violence, domestic violence, and more. And how we had to ask ourselves, are we making children and teens pay because we want to protect older, vulnerable people? That was an issue. And we had to look at the impact of the measures. Now, as for the vaccines, we didn't get all the vaccines that we wanted at the beginning. There was only a few available, and we had to prioritize the access. And then you saw all the ethics around that. How do you prioritize people? Why this group? Why not this other group? And so that was debated. And we have an ethics committee in the public health, which is associated with the National Institute of Health. So it was particularly relevant to have that ethical discussion. Choices had to be made. And it's the same thing with the treatments that are offered. We see the limits of things. There's constant ethical issues that come up. And we have to balance what is inconvenient and what is convenient about it. But we have to look at how it affects one group of people. How do we make a choice? But we don't want to mortgage people's futures. Some choices were made from the federal government, some were done in the regions or the province. And the one important issue was to say, we want to keep society relatively functional. I say that in quotation marks. We're a lot of people who work in health, and people need to be able to continue to live and work and do things in this period of time, in spite of the way it's affected, and stopping certain activities could be an important health measure. I'm not saying that what's happened has been perfect and problem-free, but the society was on pause. We had to partly protect people, and now we have to get society getting again. Other societies made different choices. In some cases, it was more severe than ours, and these are social choices. I'm not just in pure health care here. I'm talking about social aspects, public aspects. I have other questions, but participants have questions as well. So Hélène Boisjoli says, she asks a difficult question. So with some hindsight, because of a aerosol-borne virus, do you have any comments about the deciders who didn't seem to be very interested in issues that had to do with ventilation, especially in school contexts or older or older people. And what about the antivirals? Well, I'm very glad to actually hear this question. I didn't want to go into too many issues that were scientific in nature, but knowledge has really increased in the last 2 years on this subject. And our plan, our pandemic plan had to be adjusted because with time we figured out the transmission and we were able to demonstrate that. And we were able to show the principal and the secondary way. So the first one was through aerosols or mini aerosols that were transmissible within a short distance, which is to say less than 2 meters. As time went by, we showed that there could be an aerosol transmitted. In other words, more than 2 meters in certain circumstances. For instance, if something had been manipulated or there had been somebody was in ICU, but also if we found people that were in closed, poorly ventilated places where they're close together. At a certain point, certain aerosol particulates could be accumulated. So that was saying, okay, what's more important? Are we really talking about a short distance transmission or long distance? And the science right now, and I know it's evolving a lot, we may not, we don't have all the knowledge still, but what we can see is that most cases, the transmission is within a short distance. There are times when we have found that ventilation played a bigger role or poor ventilation. So ventilation in schools is something I've been dealing with for a long time, and they really haven't, it hasn't evolved in 20 years. We've made recommendations, but we really need to look at them, put them in, follow them up, and they all have to be put in retroactively. Among those recommendations, well, some of them were followed and were monitored, but was it quick enough? No, nothing's ever quick enough. Is it being done? Well, it hadn't been done for 20 years, so at least some of it's being done. So the question is, should we be putting in portable ventilation units inside of every classroom with HEPA filters? Yes or no? Answer, well, unless it's the exception of the exception, it's totally not the way to go. What we need are actual real ventilation systems in the classrooms, especially in primary and second and high school. In the university, it's perhaps less necessary. So we know that any mechanical system obviously needs upgrades and it needs maintenance. So what we need are mechanical ventilation systems everywhere, and we improve what's there. So the debate isn't that we didn't deal with it, but it is an absolutely humongous task to undertake, and it's being done. But we can't imagine that within 1 year, we'll be able to catch up on 20 years of neglect. And that is really a problem. So was a recommendation made? Yes. Is it being followed? Sort of. Quickly enough? No. And I think that we're going to have to be very vigilant. But you can see that I'm kind of managing, I'm playing here on all tables. We have to invest a lot of money into ventilation, for sure. But I think we should also be very careful. And some people have mentioned this. We have to say but that, we need to improve that, but that doesn't mean that a portable HEPA filter is a solution. So the scientific data doesn't support it. So we haven't, we shouldn't go to extreme. Sometimes there are very specific circumstances, and we need to be careful not to get too extreme, because otherwise we get into something that science might not actually recommend. Here's another question from Hélène Carabin. So to follow up on that question that you just answered, because the virus is animal in origin, which means that it infects a lot of animals apart from people. I think today they talked about an infection coming from a deer and from bisons to people. What is public health doing to approach to monitor this situation that might go into the population? For instance, veterinarians were discouraged from testing cats, family pets. Well, our approach was very important and I think very useful. I must confess that in the last 2 years, we have really dealt with the human-to-human transmission. And as long as we're in an actual pandemic, it's difficult not to do that, quite frankly. If we get to the point where we can eradicate the disease completely, then at that point, every reservoir of disease will become important. But because of the transmission from animal to human has definitely not been the factor that supported the pandemic, because it may have been the spark, but certainly not the fact that it kept persisting. It was human to human only. So the human to human transmission, I think, will go down, and then we'll have time to look at the other. But we have to think about what we really had to deal with, what was really going on, and the transmission was happening between people. And that doesn't mean, of course, though, what you raised isn't important, and the health of animals is very important, and the contacts that people have with them are important too. But certain studies were looked at to see if cats or dogs could be vectors. There might be, but it was very much in a timely kind of way, and definitely not the main mechanism. The approach stays in. If you'll allow me to get out of my role as an interviewer, Hélène says, for older people, their companion animals are very important, and they were deprived of social contact for months on end, and now we can see that it was a very heavy price, a burden to pay. But what is positive is that those seniors who did have pets had a very important part of their lives. So we're very grateful to the veterinarians who did research, and we knew that cats were not a big problem, and with dogs neither. So that was very reassuring. I would like us to right now talk about another question you haven't mentioned, but because you're no longer on the front lines, you were working in Nunavik back in the day, and how things were, how were things going with Indigenous populations from a point of view of research? What did you notice the most when you were still up in Nunavut? I was working for Nunavik, sorry. But there are things that applied to Cree communities as well as to the other treaty or non-treaty Quebec indigenous populations. There's a lot of different communities who have different approaches, and we need to respect those approaches. They're autonomous, they have their own belief system, and they have their own ways to determine their priorities. So this is necessary. So let's get back to Nunavik. We wanted, of course, to reduce transmission risks for COVID, and it worked quite well until Omicron showed up. There was about a few dozen cases that were imported. But during the 18 months before that, there was very, very little transmission of COVID. But with Omicron, it became totally crazy, impossible. And why? Is because people had no symptoms and they developed minor symptoms. But at the time when they developed them, they had already transmitted the infection to several people, even though they were vaccinated. So it was a wave that was literally impossible to stop. So we were confronted to people in some communities who had been vaccinated, as much as in the southern areas, and in other communities who said, I don't want to be vaccinated. So we have vaccination rates that are quite variable over there. So for us, it's really difficult to see that. When I would leave Nunavik, I would go to an Atikamekw community where they had hundreds of cases, where had lots of deaths of entire families that were decimated. And in spite of that, the vaccination rate is 40%. Why? Because people feel that this triggers an ancestral trauma because of white people who have in the past imposed different measures, whether it meant tuberculosis in the old days, which was exported to the community, and any sanitary measures that are imposed by whites is, gives way to resistance because of trauma. So it's a phenomenon we really need to understand. We could say, yes, but it was a long time ago and all that. No, but it wasn't that long ago, and it was really huge. And that's something I learned, is that trauma is something that needs to be understood and listened to. And the other thing that we have to listen to is that it might be from leaders or traditional leaders. They play a huge role in the small communities, and we need to identify the leader in a small community. Of course, they're very important, but this work means that when you work with Indigenous communities, you really need to listen, and you need to be able to speak to them and dialogue. I'll give you an example. So, and this has happened in several communities. They didn't want to cover the schools, and even now we see this happening. We think that we could, but people are reticent because they want to have their own control measures, and we need to listen to them. So we can give them the information, it'll give them an impact, but we can see that it can be quite difficult. Science is science, of course, but social governance is different, and social perceptions differ from one place to the other. And we have to see that there are certain communities, they're there are people, communities of people who have chronic diseases. They have other issues. There's bad ventilation. They're close to each other because of where they live. And we also find the same thing in the education arena. So there's a lot of risk factors that are really important. And once again, the solutions offered cannot be imposed. They cannot come from the outside. It cannot be something that has to be explained and then discussed with the. So we have another question from Michael McKenzie. I hope I'm going to translate properly. Our structure, political Canadian structure, whether it's federal, territorial, or else, created a confusion because of the scientific efforts in order to manage this crisis across the country, especially in the last year. And if so, what can we do in the future in order to reduce the level of confusion? There's been a lot of effort across Canada to, we've tried to develop knowledge and share that knowledge. And there's been a lot of initiatives, like a lot of the studies in SARS-CoV-2 and diagnosis methods are published, and they're very important. It's important to be able to get a hold of that knowledge. It's useful, but that data is not enough to have it. You actually have to share it, and you have to share it quickly because you don't want it to arrive too late. So one thing I'm critical of is that we've seen data arrive via the federal government, and they came a little too late. We were interested because these were very well done, of course, but all they did was come to corroborate what we already knew before that. So I'm just saying that it is important, but unfortunately, it wasn't always a timely thing. Sometimes it was coming in a little bit too late, even though it was well, it was worthy. Well, we're almost done. It's almost 2. Before giving the floor again, do you have any advice to give to the members of the Academy who are trying to transfer data to the deciders to make sure that the Canadian population be healthier? So that's just one concept among many here. Transfer information. Well, we listen, we hear, and of course, we're very, very interested in that data. We mustn't think that they're all going to be used all at once, but rest assured, we really need that data. And I'm so happy that the scientific community has supported this and supported it's so important you can't measure it. Okay, so thank you very much. It's my turn to thank you warmly for having been part of this dialogue. So Richard Massé, richardmassé.ca, you can ask him questions after. And now I will give the floor back for today's conclusion. Thank you so much, Dr. Massé. And Madame Reynaud, thank you so much for this very, very interesting and important discussion today.
Pandemic, and to me, it's quite remarkable when the general public knows the names of our public health officials, maybe even more so than our politicians. So that says a lot about the importance of public health officials in this thinking. We owe you, Dr. Massé and Dr. Reynaud, who work in public health as well. We owe you a great debt for all the work you do. It's complex because you're dealing with incomplete information, competing interests, including political, and you're dealing with not just medical science, of course, but social science, and something that probably not many of us were actually trained in, and yet we've had to practice that. And you do it at a speed that's faster than the speed of science. So thank you very much. Dr. Massé, I really appreciated your comment about how you bring people together and you use the term plagiarism when you're taking information that may not have gone through normal peer review or publication processes and you're using it to great advantage. And I think that's a great lesson for all of us that are more traditional scientists and not having to deal with working at something that's faster than the speed of science. So thank you for your comments. Before we leave, just for the audience and the panelists, please take note that there'll be future episodes in our dialogue series, one coming up in mid-March. And so scheduling information and topics will be made available very soon. So pay attention to that. So to all, thank you all for attending today's dialogue. Merci à tous. À bientôt.
Au revoir.
Merci. Au revoir.